Today we would discuss about the antibiotics and antimicrobial agents. So let's start the presentation. See, to counteract the different microorganisms, we have three varieties of the drugs. The first is antibiotics, second is antimicrobial agents, and third one is chemotherapeutic agents. We would discuss the detail about these terms. What are the antibiotics? See, these are the natural substances produced by various species of microorganisms like bacteria, fungi. What they do, they actually suppress the growth or kill other microorganisms, means produced by some microorganisms, and they have the capacity to kill other microorganisms. The second variety is antimicrobial agents. So let us not confuse between the antibiotics, antimicrobial agents, and some cytotoxic and other types of the agents. They include synthetic as well as naturally obtained drugs that attenuate microorganisms. And then the third is chemotherapeutic agents. The drugs in this class differ from all others in that they are designed to inhibit, kill the infecting organism and have no minimal effect on the recipient. So, these are some targeted molecules that are used for the management of some microbial afflictions. Let us talk about the microorganisms. What are the microorganisms? Microorganisms of medical importance fall into four categories. First is bacteria, second viruses, third fungi, and then parasites. So talking about them, when we use a particular drug like against the bacteria, then it is known as antibacterial, that is viral, that is antiviral, fungal, that is antifungal, and parasitic, that is antiparasitic agents. So these are certain groups. Now prior to the details description, let us discuss about the mechanism of action. The agents that inhibit synthesis of bacterial cell wall, the first thing, they are the penicillins and cephalosporins, cycloserine, vancomycin, bacitracin, and azole antifungal agents, all azole like clotrimazole, fluconazole, itraconazole, they all inhibits the synthesis of bacterial cell wall, that is their mechanism of action. There are agents that act directly on the cell membranes of the microorganism, cell wall and then cell membrane. They are polymyxin, then polyene antifungal agents like nystatin and amphotericin B, and what they do, they alter cell membrane permeability, so leakage of intracellular component. Agents that bind to the 30S ribosomal subunit and alter protein synthesis, which eventually lead to cell death. So ultimately the aim is to produce the cell death. They are aminoglycosides. The aminoglycosides, they are the drugs like the gentamicin, amikacin, natilmycin, etc. So what they do? They bind to 30S ribosomal subunit and alter protein synthesis. They are rifamycins, which inhibit RNA polymerase, क्विनोलोन्स में सारे जो सिप्रोफ्लॉक्सासिन, ऑफ्लॉक्सासिन, स्पारफ्लॉक्सासिन, these are included in the quinolones, which inhibits topoisomerases. So they affect on the nucleic acid material. There are certain other varieties which acts as antimetabolites. So they includes trimethoprim and sulfonamides. So trimethoprim and sulfonamides are the initial classes of the drugs, which are also known as the sulfa drugs like Septron and others, bacterium sort of things which have been which were used initially for the antibiotic properties, but nowadays they are not frequently used. Now we come to the antiviral agents. As you know, the virus contains a very specific type of nucleic acid as well as the DNA and RNA. So what the antiviral agents do? There are some who acts on the nucleic acid analogues, some non-nucleoside reverse transcriptase inhibitor and inhibitor of viral enzymes. So types of action. The broadly when we talk about the antibiotics or the antibacterials, they perform two types of the action. First is bacteriostatic and second bactericidal. Static means to check the multiplication of the bacteria, and bactericidal who directly kill the bacteria. So the bacteriostatic agents, among the groups of the antibiotics, the first group, that is sulfonamides with sulfa drugs, tetracyclines, chloramphenicol, and this is the macrolide group. In the macrolide group, basically the erythromycin, clarithromycin, roxithromycin, these are the drugs, and ethambutol, they are the bacteriostatic agents, means they check the multiplication and the growth of the bacteria. The bactericidal agent which actually kill the bacteria, they are penicillins, cephalosporins, carbapenems. These are the latest high-end antibiotics, different types of the penems. Aminoglycosides which includes the gentamicin, amikacin, etc., rifampicin, anti-tubercular drug, isoniazid, that is also anti-tubercular drug, and pyrazinamide, that is also an anti-tubercular drug. Apart from that, the cephalosporins, vancomycin, nalidixic acid, ciprofloxacin, metronidazole, and cotrimaxole, they are also the bactericidal agents. Some primarily static drugs may become cidal at higher concentration, means we cannot say that if a drug is static and in the higher concentration it may lead to the cidal action as attained in the urinary tract and vice versa. The spectrum of activity, as per the spectrum of activity is concerned, there are certain drugs which act on a narrow spectrum basis, means on a particular part on or on a particular type of organisms, and there are certain antibiotics who are broad spectrum, which causes the cidal effect to the all types of bacteria, either they are rod shaped, either they are cocci and others, pseudomonads, etc. So these are the two spectrum of activity. Let us talk about the these drugs. The narrow spectrum drug, they are penicillin G and streptomycin, and the broad spectrum drug, they are tetracycline, chloramphenicol, etc. Now, when we actually provide or prescribe the antimicrobial therapy, what actually we have to do or think? The first is the concentration. The site of infection concentration should inhibit microorganism, means suppose there is a colony or the multiplication of bacteria at a particular site, so the drug should reach there in adequate concentration to kill the bacteria. Simultaneously, it should be below the level toxic to human beings. Now we cannot exceed the normal amounts, because if we give the amount that is toxic to the human being, it may cause certain other side effects. So we have to measure the specific amount that is properly have the cidal effect at that particular side, and within the limits, it should not cross the limits so that it causes toxicity. The host defenses, which includes the immunity intact, means if the defense immunity is okay and the body can fight the bacteria, So, in that condition we can prescribe the bacteriostatic drug, means we can check the growth of the bacteria and the rest of the things are taken by the body. But in case of the compromised immunity or impaired immunity, we have to prescribe the bactericidal agents which kill all the bacteria present at that particular site. The source of antibiotics, that are the natural compound acting against the different types of the bacteria. The source are fungi, bacteria and actinomycetes. Now, in the different category, if we talk about what are the antibiotics that are derived from the fungi, the first penicillin, which was discovered from a fungus, the griseofulvin, it is an antifungal agent, and cephalosporins, that are also antibiotics. Majority of the cephalosporins, they are broad spectrum antibiotic. The antibiotic that are derived from the bacteria, they are polymyxin B, colistin, bacitracin and aztreonam. And the antibiotics that are derived from the actinomycetes, they are aminoglycosides, means gentamicin, amikacin, etc. Macrolides. Macrolides are the erythromycin, roxithromycin, clarithromycin, tetracyclines, polyenes and chloramphenicol. They are derived from the actinomycetes. Now, we come to the resistance. This is an important aspect. Like in the virus, there are mutations which causes the drug ineffectiveness. In the same way, in the bacteria, the resistance is an important aspect. So, the bacterial resistance to antimicrobial agents has three general categories. Drug does not reach its target, means the concentration at the site of infection may not be adequate. Second, drug is not active, that is reversed by the bacteria, and target is altered. So, there are three conditions where the resistance may occurs. So, what happens? Let us describe it in the details. The drug does not reach its target. First, porins, absence, mutation, reduced drug entry into that area, reduced effective drug concentration at the target site. Efflux pump, transport drugs out of the cell, resistance to tetracycline and beta lactam antibiotic. The beta lactam produce bacteria, they cause the ineffectivity to that particular drug. Then the inactivation of drug. Second general mechanism of drug resistance is beta lactam antibiotics. The beta lactamase produce antibiotic, they can reverse the action of that particular antibiotics. Aminoglycosides, the aminoglycoside modifying enzymes, they can modify the action of these antibiotics. So, we just combine certain cephalosporin or penicillins like the ampicillin and cloxacillin with the clavulanate to just reverse the action of the beta lactamase. Failure of bacterial cell to convert an inactive drug to its active metabolite, that is an important aspect. There is a resistance to INS in Mycobacterium tuberculosis. So, in the tuberculosis, this resistance is very common, where the multi drug resistance tuberculosis causes a challenge to the recovery of patient. Now, alteration of the target, mutation of natural target first, and regarding the target modification, the new target does not bind the drug for native target, resulting in resistance to antibiotics. Components mediating resistance to beta lactam antibiotics in Pseudomonas aeruginosa. Beta lactam antibiotics hydrophilic must cross outer membrane barrier of the cell via outer membrane protein channel of porins. Mutation missing, deleted, drug entry slow or prevented. Beta lactamase concentrated between the inner and outer membrane in the periplasmic space constitutes an enzymatic barrier, drug destroyed and effective concentration not achieved. Regarding the target, PBP penicillin binding protein, low affinity for drug and altered. So, efflux transporter max A, max B and OPRF pumps the antibiotic across the outer membrane, reduce intracellular concentration of active drug resistance. Let us talk about the mutations. May occur in target protein, drug transport protein, protein important for drug activation, random events and survival advantage upon re-exposure to the drug. So, resistance is acquired by horizontal transfer of resistance determinates from a donor cell, often of another bacterial species by transduction, transformation and conjugation. Insatiable need for new antibiotics. So, what happens that in due course of time when we actually a bacteria develops the resistance to a particular antibiotic, we need to alter the structure of that particular synthetic molecule in or so that we can just reverse that particular resistance. So, resistance may occur at several levels as told earlier in these slides. So, emergence of antibiotic resistance in bacterial pathogen both nosocomially means in the hospital acquired and in the community setting is a very serious development that threatens the end of antibiotic era. Responsible approach to use of the antibiotics. So, in that way the rational use of antibiotics should be achieved. Now, you have seen that in majority of the setups, even in very trivial infections, the people just prescribe the high end antibiotics. In my opinion, the high end antibiotics should be reserved to the serious infections and hospital bound infections, and in a normal course let the body try to reverse the effects of that particular microorganism, and one should try to give the patients a very simple antibiotics in simple infection, the moderate antibiotics in the moderate infection and the high end antibiotics in the severe or life threatening infections. Now, let us talk about the cross resistance. Acquisition of resistance to one AMA conferring resistance to another antimicrobial agent to which the organism has not been exposed is called cross resistance. Resistance to one sulfonamide means resistance to all others. So, suppose there is a macrolide group, and if a bacteria achieve the resistance to the erythromycin, so it is more likely that that particular bacteria may develop the resistance to other group antibiotics like roxithromycin and clarithromycin. So, resistance to one tetracycline means insensitivity to all others. So, it completes the cross resistance. One group that is very much effective against the gram negative bacteria, they are aminoglycosides. They are somehow the different, because in this group we have different type of drug like gentamicin, amikacin, natilmycin, etc. So, resistance to one aminoglycoside may not extend to others. Gentamicin resistance strain may respond to amikacin. So, this is the partial cross resistance. Sometimes unrelated drugs show partial cross resistance like tetracycline. If a particular bacteria is resistant to tetracycline, it may become resistant to the chloramphenicol, which is not a drug of tetracycline group, but a drug of the second group. Let us talk about the prevention of drug resistance. So, use of antimicrobial agents should not be indiscriminate, that is very specific. In normal setup, if it is possible, one should try to do the culture of a particular secretion either from the respiratory area, either from the urine, stool, whatever, and then after use the antibiotic in a very judicial manner. That should not be inadequate, means a particular concentration should be achieved. If we give the less dose, then there are fair chances of development of the resistance, and one should not unduly prolong the medications so that the bacteria may become resistant. Use rapidly acting and narrow spectrum antimicrobial agent whenever possible. Prevention of drug resistance. Now, combination of antimicrobial agents. Whenever prolonged therapy is undertaken, like tuberculosis or subacute bacterial endocarditis, infection by organism notorious for developing resistance, they are Staphylococcus, E. coli, Mycobacterium tuberculosis, must be treated intensively, means with a specific planning, and one should try not to